Hi, I'm Julia Resnick from the American Hospital Association. In September 2020, AHA partnered with the Advancement League to host a virtual event for emerging health leaders. We discussed how to create a more equitable path forward for maternal health. In this video, you will hear insights from two physician leaders who offer solutions for improving maternal health equity. AHA's Aisha Saeda moderates the conversation with Dr. Lee Beers, Medical Director of the Child Health Advocacy Institute at Children's National Hospital, and Dr. Deepa Kumaraya, Vice President of Clinical Service Lines and Transformation at New York Presbyterian.
My name is Aisha Saeda. I'm a Program Manager with the American Hospital Association. During the COVID-19 pandemic, OB services has been the only service line that's been active. We know we need to work together to recognize and address the disparities mothers have been facing to achieve maternal health equity. We have an outstanding group of hospital leaders joining us today who will share what hospitals are doing to address maternal health equity during and before COVID-19. Dr. Lee Beers is the Medical Director for Community Health and Advocacy at the Children's National Hospital and the President-elect at American Academy of Pediatrics. She is the founding director of the DC Mental Health Access in Pediatrics program and the co-director of the Early Childhood Innovation Network. Thank you for being here with us, Dr. Beers. We talked a lot about data today. From your perspective, from a hospital perspective, can you talk about what steps hospitals need to be taking to achieve a maternal health equity and address disparities?
Yeah, absolutely. So, I think it's a really important question and I appreciate it. One of the things that we've certainly heard all through the day is that not every patient experiences our health systems in the same way, right? And so we need to really be able to use data and disaggregate it as much as possible to really better understand what the experience and outcomes of care are for the patients and families who are coming through our systems. I also think it's really important for us internally as hospitals to be able to use data to understand how we are doing as health systems. We had a great conversation in our breakout group just about how patients and families don't always feel heard by their providers or their health systems. And so we need to be able to use the data to better understand how we are doing. I think, the other point that I would make is that the quantitative data is really important, but the qualitative data is also really important. It gives us a better frame, I think, for how to interpret the quantitative data, and it gives us more insight into how we're doing and how we look for solutions.
We also have Dr. Deepa Kumaraya. She is the VP of Services Line and Clinical Strategy and the Associate CMO at New York Presbyterian Hospital. She is also an assistant professor of medicine at Columbia University Irving Medical Center. She provides leadership, strategic vision, and management for the clinical service lines and the integration across all New York Presbyterian hospitals and medical groups.
So just to add on to a couple of points there, I think one of the things we've heard a lot about is sort of the journey of women, whether it's your journey through your obstetrical care or really the journey of women's health. And I think one of the places that hospitals can play a big role as aggregators of data is seeing our patients through that whole journey and connecting, whether it's an experience that happens in the emergency department or experience in a clinic or an experience with one of our CBOs as part of the story we all see of women as they come through our healthcare system, and ensuring that we're setting up a data infrastructure to connect those pieces so that we can better have the whole picture of the person that we're caring for at whatever instance, they're within our walls. I think another thing COVID really brought to bear, there's been much published about the variability in outcomes based on race, ethnicity, and Black and Indigenous populations have had significantly worse outcomes when we as many health systems looked internally. These are not new issues. Our capture of race ethnicity data is poor. And it was even worse during COVID, frankly, because the patients were coming in quickly and they were getting registered quickly. We were just capturing that information. So I think it's incumbent on hospitals to think through now and in sort of quiet time, so to speak, how do we real time and always be capturing real data, sort of race, ethnicity, language, and zip code information on our patients, and again, have platforms such that they can be self-reported. And we know that's the best practice, we have to be doing that in all times so that we can then look on the data and ask ourselves the questions, how can we improve?
And we know with COVID-19, it has challenged us in so many ways, but mostly encouraged us to innovate the way that we deliver care. Dr. Beers, can you talk about how Children's National Hospital is innovating and engaging with other community stakeholders to provide those equitable opportunities for mothers?
Oh, yeah, absolutely. I'd be delighted to. And I think maybe the first thing I'll chime in about is why we're even talking about a pediatric hospital, right, a children's hospital in this discussion of maternal health. And this is actually something I love talking about because I think it's really important. As pediatricians, we see families from the moment a baby is born, and often before that, often prenatally, either for prenatal visits or if there is a concern during pregnancy, we may see them during pregnancy as well for the pediatric consult. But we're sort of part of that health system, and I think some of the data we looked at earlier showed that there's a significant amount of maternal mortality that happens after birth, and a significant amount that's tied to maternal mental health as well, which is something that I think we as pediatricians and child health systems are really set up to detect and support families in. So we've been doing lots of work in this area for a while at Children's, but actually very recently, I'd love to share with you a little bit about a new initiative we've launched, actually through a really generous partnership from a local partner, the A. James and Alice B. Clark Foundation. We started something called the Clark Parent-Child Network, and this is a hospital and community-wide network, which builds on just this really strong foundation of innovative and collaborative work that we'd already been doing, addressing both perinatal and maternal mental health, actually, but also how to promote healthy brain development in infants and young children. And those things, of course, are inextricably connected. So our network has two pillars. There's a perinatal pillar, which is led by our Developing Brain Institute. And part of what that perinatal pillar will do, a big part of it, is really focusing on community collaborations to build out really innovative maternal mental health interventions that start with screening, but that aren't actually using some technology solutions as well that start with screening, but don't end with screening, and then really following that and sort of being able to really evaluate and assess what the impacts of these maternal mental health interventions have on the developing fetal brain. And so then the other side of that, we have our infant toddler pillar, which is actually the part I lead. It's led by our Child Health Advocacy Institute, and that leverages work by leaders and programs across our institution who are doing a wide variety of things focusing on family-centered two-generation approaches. So early childhood mental health support for adolescent-headed families, a wide variety of other things, integrated mental health care in our systems. But one of the things we're really that will connect through all of the network is building a work on community core, and so we'll be bringing parent advocates, parent support workers in all of our primary care clinics to really help connect and support these linkages between all the different health systems, the obstetric health systems, our community health systems, our community core, to really help bridge those connections, but also help build trust and tendency on the part of our medical providers. So I think another really important thing is that both these pillars really have and will rely heavily on parent and family leadership within the network, and we work with institutions across DC as a part of that larger network as well.
Thank you. I think the one thing that we always say is that we can't do this stuff alone. We need partnerships, and we need to partner with our communities to understand their needs better and serve them better. Dr. Kumaria, from your perspective, how is New York Presbyterian combating the fundamental causes of maternal health inequity, especially during the time of COVID when New York was hit so hard? Can you share a little bit about that?
Sure, Aisha. One of the things that Dr. Beer said really resonates, and that's that sort of maternal-child connection and really thinking about a two-generational approach and a holistic approach. So a program that we've been working on is our Healthy Steps program, which is, again, very much focused on not only the mom, but the child, and adding behavioral health. So we're focused on using our community health workers in partnership with our families, and really our families in their whole, in the sort of the whole form, in thinking through how we can address a lot of the issues that women face. I think the postpartum period, if we looked at the data that was shown earlier, that's a very small period of time where there's 30% morbidity and mortality to moms. And partnering with, again, CBOs in our local community to offer postpartum doula services. And I think it's incumbent upon the hospital to think about our very traditional forms of care delivery and how we make them more collaborative to meet the needs of our community. So that's talking to our communities, hearing them, listening to them, and then subsequently modifying our programs to meet those communities' needs. So postpartum doula programs, sort of family-oriented programs. And if I may say, during COVID, and as it was noted, the obstetrical world flipped to telehealth because we had to. 50% of visits on average in some practices turned to tele. But when we took an internal look at our program, there was great variability, anywhere from 10 to 50% depending on the location. And it's a lot of the issues that we've talked about on the call before: accessibility to technology, Wi-Fi broadband connection, language support services. And so while we really think that a virtual connection to our patients, which allows us to be there for them more, and families more continuously, we're very cognizant and spending a lot of time, energy, and effort on how we ensure that we're not introducing a new bias through the utilization of technology as such a potential core for our OB and other services.
And are there any practices that you've adapted due to the pandemic that you see your hospitals continuing in the future?
Yeah, I mean, absolutely, lots of them. I think the virtual connections that have been created have actually been really powerful. I mean, I think there are barriers there, and important things to think about around access and disparities around telehealth, but there's also been some really fabulous connections. We've been able to do some virtual, what are called parent cafes, so sort of parent support settings, but do them virtually. And that's really, I think, built up a lot of support among some of the parents. Actually, in our Healthy Steps program, too, we have Healthy Steps as well. But it has created, I think, a sense of trust and connection among mothers that has given them a bit more support and given them, I think, a stronger connection to the health system.
One other area, we started to see women more often and babies more often in our sort of PUI clinic. As COVID was happening in New York, patients were coming in and out of our system more quickly, and like everywhere, people are trying to understand how do we care for family members and teams of people when we don't really understand this disease process. So it allowed us to connect more frequently and often with families, and that is something, as we, again, learning the process as we were going along, that we know we need to continue. And I think in addition to having much more touch points with moms and with families, we need to collect, just to sort of circle back to the first point, the data around it, because if there are individual instances of connection, but we're not pulling it back to how can we then say this is a resource this community needs, and we need to think about it at a more systemic level, then we may be more connected, but we may not be thinking of the systemic solutions therein. So I think staying more connected with a variety of tools. We were using a lot of Doppler devices and home blood pressure monitoring devices. How do we think about having wearables and other tools in the community, but pulling that data up so that we see places that things are working and places where we need to provide more support.
How do you see the role of hospitals changing in regards to maternal health equity? Are there some ways that we can ensure that all hospitals and health systems are offering equitable care to diverse mothers? Dr. Beers?
I actually think one of the most important things we can do is better integrate and elevate the patient and family voice. I think that as health systems, we are frankly, just notoriously bad at that. And we need to get better, because that is the only way that our systems are going to improve and become more equitable. And so I think that's hard, right? And it requires actually investment of time and resources and finances to be able to do that in a really robust and ethical way. But I think it's the only way that we'll really be able to move forward. So if I could put one big change, I think that would be it.
Dr. Kumaraya?
So I think one of the things that we hospitals really need to look at is to look at our data by race, by ethnicity, by language, and we look at our outcomes often, but in global context and not individually. And another thing, as we faced COVID and as we faced a racial justice crisis in America, one of the things New York Presbyterian has done is put together a Center for Health Justice. And I think because so many of these things are not about one service line or one disease condition, they're about the way our healthcare system is, the culture of our healthcare system. And so thinking through education, training, and a continual culture of equality, equity, but that requires giving people across the organization language and tools. And so that's sort of global implicit bias training, really understanding the way the patient shows up for the care and what they're experiencing before they're coming in. And that's everybody. That's not just the physician or the nurse practitioner or the midwife or the doula. It's the person at the front desk, the check in, check out. It's somebody that they may see as they're passing in the hallway. And so I think thinking about every member of our healthcare community within the walls of a hospital and beyond, and how we can be part of that sort of changing culture.
So just wondering, what are some, recommendations or thoughts that you have for those leaders that are coming into the medical field and learning about maternal health?
Maybe I start by saying I see maternal health and maybe women's health as one of the most critical issues is the wrong term, one of the most critical areas we need to focus attention to as a healthcare system. Women are 50% of the population, women make many of the healthcare decisions, and that lens of their healthcare throughout the journey of their life is an important one for hospitals, quite literally, and one that a lens we've not often looked at. And so I think that there is only opportunity for anyone willing to think differently, to bring their experience, to really bring hospitals into a more modern era, frankly, for women's health in a more global way.
I think I agree, and the two things I would add is first, really take it upon yourself to learn, and I think everyone's spoken about this, to learn about the inequities and disparities that exist in our healthcare systems and in our country. Take that upon yourself to really be learning and educating, because that's incredibly important. Both through reading, but also through talking to patients and families and asking them what their experiences have been. I think that would be one. I think the second thing is honestly just put aside whatever imposter syndrome you may have, and feel confident and feel confident at stepping in and thinking about how we together can really innovate and change our healthcare system for the better, because it's going to take all of us, and it's going to take a wide variety of perspectives, and our young leaders have really important experiences and perspectives to bring to the table.
Thank you so much, both of you, Dr. Beers and Dr. Kumaraya. It was wonderful having you on this panel, and we hope to hear from you soon. Thank you so much.